Let's begin with the CPT nervous system part 2. Here we are going to see some more medical coding guidelines. Now the first topic is surgery of the skull base. The surgical management of the lesion involving the skull base, that is the anterior, middle and the posterior cranial fossa, often requires the skill of several surgeons of a different surgical specialties working together or in tandem during the operative session. These operations are usually not staged because of the need for definitive closure of dura, subcutaneous tissue, and the skin to avoid serious infections such as osteomyelitis and or meningitis. Now, here I have given you the diagram of the base of the skull, and you will see that the base of the skull is divided into three different compartments. This is the anterior compartment, which is formed by the frontal as well as the ethmoidal bone. I am giving you this bone's name because sometime in the anatomy it is asked that what is the bones that form the anterior cranial fossa, and then the middle cranial fossa, which is mainly formed by the yellow color sphenoidal bone, and then the temporal bone, and even the parietal bone. And this is the occipital fossa, which mainly consists of the the occipital bone. So these are the three cranial fossa, and if you see the code range, you will see that the code range also have the name anterior cranial, medial cranial, and posterior cranial fossa. And similarly here also. Now there are three important terminologies also where you must have seen, that is the approach procedure, definitive procedure, and reconstruction. So what are these that we are going to see in the next slide? So in the context of the skull-base surgery, in the CPT code, the approach refers to the method used to gain the access to the area needing surgical intervention, and the definitive procedure describe the actual surgical manipulation performed for the lesion or the tissue. So I have given the little bit of description of the approach and the definitive, and reconstruction is basically, it is reported separately if extensive dural grafting, cranioplasty, local or regional cutaneous pedicle flap or extensive skin graft are required. So for example, imagine the surgeon needs to remove the pituitary tumor. So the approach could be the endoscopic or endonasal approach to restill the pituitary gland, and definitive procedure will be removal of the tumor itself. So pay attention, what is the approach, what is the definitive procedure that has been carried out, and even the reconstruction. The reconstruction usually happens after the defect has been removed. So once the defect is removed, in case if it requires a grafting or the pedicle flap, that happens after the removal of the defect, removal of the tumor. Now let us understand what are the important points a coder should ponder upon. So first is identify the procedure, whether it is an approach, whether it is a definitive procedure or the reconstructive procedure. What are you coding for? Then secondly, identify the anatomical location. Where did that operation happen? Is it anterior cranial fossa, middle or the posterior cranial fossa? Then identify the surgeon for reporting procedure. So when one surgeon perform the approach procedure, another surgeon perform the definitive procedure, and the third surgeon perform the repair or the reconstructive procedure, every surgeon reports only the code for the specific procedure performed. So like the approach is done by surgeon A, so he is going to write the code for the approach, because we have a separate code for the definitive, approach and reconstructive. Now suppose if one surgeon perform more than one procedure, like he has performed approach as well as the definitive procedure, then both the codes are reported by adding the modifier 51 to the secondary additional procedure, which is very important. Now let us take one example for you to understand how to do the coding. Dr. Adams performed an excision at the middle cranial fossa for a vascular lesion. This procedure was completed in intradural fashion with a dural repair and a graft. His partner, Dr. Evans, performed the infratemporal approach with decompression of the auditory canal. How should Dr. Adam report her service? And we have the code. Now we need to find out how many surgeons are there. There are two surgeons, right? Dr. Adam and Dr. Ivan. So first find out what is the role of Dr. Adam. Dr. Adam is excision at the middle cranial fossa, because Adam is doing what? Excision of the middle cranial fossa, and he is actually doing the definitive procedure because he has excised the lesion from the middle cranial fossa. Dr. Ivan perform an infratemporal approach with a decompression of the auditory canal, because here we can see that he has performed the infratemporal approach, and anatomical location is middle cranial fossa. Now the important thing is, whenever there are two surgeons which are involved, please pay attention that what is the question. What they have asked is, you have to code only for the Dr. Adams service. What is Dr. Adams service? It is a definitive procedure. So I'll be coding for that. So whenever you are attempting any questions related to the cranial surgeries, please pay attention how many surgeons, and did they tell you to code for the complete procedure, or did they tell you to code for the particular doctor's work, because that is very important. And here they asked me for only Dr. Adams service. I'm going to code for that, and for that we have the code 61606. Okay, and we will write that code. So let us take one example. 50-year-old male is diagnosed with a tumor of the skull base just below the occipital tonsil. The neurosurgeon performs a transpectoral approach to the posterior cranial fossa. He then performs an intradural removal of the tumor of the posterior cranial fossa at the base of the skull. Dural repair is done and the area is closed with a neurolon. What CPT code? Now, first of all, how many surgeons? Only one surgeon. Has he done both the thing? Yes, he has done the approach as well as he has done the definitive, right? Because he has done the transpectoral approach, and the definitive is removal of the tumor that has been done. What is the area? Posterior cranial fossa. Now we have just seen that if one surgeon does both the procedure, we will require two code, one for the approach, one for the definitive. Okay, that itself that will eliminate my option A and B. And now in between C and D, if you see the code 61616, that is a common code. So I'm not going to waste my time in seeing what that code is, but I would always say that please read. It is a intradural, including dural repair with or without graft. So this is for that. Now this the first code will decide my answer. So what is it? It is a transcondylar and transpectoral approach. What is our approach? Ours is transpectoral approach. So what will be my answer? You tell me. So yes, C is the right answer, because here I can see the transpectoral approach, and I will require a modifier 51. So the next topic is endovascular therapy procedure, and here is the code range. These are the various technique which we use for the temporary or permanent vessel occlusion, and angioplasty, stent placement, and administration of the agent for the vasospasm or thrombolysis that is covered in the endovascular therapy. So here you need to pay attention whether endovascular temporary balloon artery occlusion has been done, central nervous system permanent occlusion embolization. So where we have done, whether it is the central nervous system or non-central nervous system, have we carried out angioplasty or have we put the stent, all that is covered in this particular topic. So just pay attention what has been done, because the codes are very specific. We have a separate code for the stent, we have a separate code for the angioplasty. And the general guideline that if you have carried out the angioplasty in the vessel where you are planning to put the stent, we just code the stent. Okay, so that general guideline remains the same for this also. Now the next topic is a stereotactic brain surgery. This is the code range. I always tell my student that you should know little bit of the topic. You don't have to go very much in detail, but just have fair idea what is this stereotactic brain surgery. So it helps you to code it better. The stereotactic brain surgery, it is a surgical procedure where the lesion like a brain tumor is removed with the assistance of the image guidance. That is where we use the previously obtained images which are used to guide the surgeon to the exact location of the lesion to facilitate uh, to facilitate the the burning of that tumor with the help of radiation beam. Now, if you see the stereotactic brain surgery, it is not a surgery in a traditional sense, because we do not do any incision. But what we do is, suppose if there is a brain tumor here, we direct the all radiation beam here, and we burn this tumor, and that way you are actually doing the surgery, but you are not cutting anything. So if you see this code range, this is specifically address the neurosurgeon's role in stereotactic radiosurgery for the cranial procedure. And it is important for you to understand that these are the code for the neurosurgeons, and these are the code for the radiation oncologists, which basically do the physics and dosimetry, treatment delivery and management. So they are for the radiation oncology code. So what is the role for the neurosurgeon? The neurosurgeon role in this stereotactic surgery involves the execution of the procedure, including frame placement and targeting the lesion. And if you see the code, you will realize that the codes are divided depending upon how big is the target. If the target or the lesion is less than 3.5 centimeter, then we call them as a simple cranial lesion. And if the lesion is more than 3.5 centimeter, then we call them as a complex region. And then if you see, we have the additional code also for the add-on code for every primary code. And if you see the code 61800, it is basically for the application of the head frame, that is requirement for the stereotactic radiosurgery. Now let us look at the next topic, that is neurostimulator. Neurostimulator, the device that generates the electrical impulses with the help of thin wire, insulated medical wire. The neurostimulation device are implantable, programmable medical device that deliver electrical stimulation to specific part of the patient's brain, spinal cord or peripheral nervous system to help treat the various conditions including chronic pain, movement disorder, epilepsy and Parkinson. The CPT codes are used to report the procedure related to the neurostimulation implant. Now, if you see the CPT code language talk about the insertion, replacement, revision, and the removal. So, what are you doing with the neurostimulator? Are you inserting them? Are you replacing them? And this is how the neurostimulator system looks like. Okay, so pay attention to that this is the pulse generator and this is the electrode. If you remember, we have already seen this in the cardiac, where you have talked about the electrode, those are and the pulse generator. Pulse generator is nothing but the battery and then the electrode. Now, if you see the CPT codes, the neurostimulator are categorized by the location. So the neurostimulator can be in the cranial, spinal or peripheral. And depending upon that, we have a code range. Like the cranial neurostimulator have the code range from 61850 to 61888. And this could be for insertion, implantation, removal, replacement. Then we have the spinal cord neurostimulator, which are in the code range of 63650 to 63688, and that is for the spinal. And we have a peripheral nervous stimulation, which is in the 64553 to 64595. Pay attention to which nerve, whether you are doing the vagus, peripheral nerve, or the sacral nerve. So especially for the peripheral, that is an additional consideration. So here it is a table. The intracranial is basically the brain and the skull. The spinal is basically the spinal cord, which is epidural, and peripheral is the peripheral nerve. And here one must pay attention to the nerves. Then the next topic is CSF shunt. A shunt is a hollow tube surgically placed in the brain or occasionally in the spine to help drain the cerebrospinal fluid and redirect it to another location in the body where it can be resolved. A basic CSF shunt system consists of three main parts: a proximal catheter, a wall, and a distal catheter. So if this is a system, this particular part is called as the proximal catheter, this is the wall, and this is the distal catheter. Proximal catheter is inserted into the brain's ventricular system. Ventricles are nothing but the brain also has the ventricle, remember. Otherwise, ventricle means you might get confused with the heart. Okay, the distal catheter carries the CSF to another part of the body. So this is the distal catheter which carries to the another part of the body, and the wall which regulates the flow of the CSF between the two catheters. So this is the system. Again, I am telling you a bit of a knowledge about that particular topic helps you to code very properly. Now these are the code for the CSF shunt. So if you see this, both the code ranges describe the procedure which are related to the CSF shunting. It is basically a medical intervention which is used to manage the overproduction of the CSF or the blockage of the CSF. The procedure may differ slightly in the location because these codes are for the cranium and these codes are for the spinal. But the underlying principle of the draining the CSF to alleviate the pressure remains the same. Now these codes are for the cerebrospinal fluid shunt procedure involving the brain, skull and meninges. And if you see these codes, they are for involving and implanting the shunt to drain the CSF from the subarachnoid spaces. That's the only difference. Okay. So pay attention to that, what is the code range and from where the CSF has been drained. And many a time we give a particular name to that particular shunt, that if it is a VP shunt, we call it as a ventriculoperitoneal or ventricular pleural. That means from the ventricle, the fluid has been drained into the peritoneum or the pleural cavity. So pay attention to that. So these are the code for the CSF shunt, that is mainly for the skull, meninges and the brain. And if you pay attention to the code, one is for the replacement, one is for the reprogramming, one is for the removal. And what are you removing? Are you replacing the ventricular catheter? Are you reprogramming the CSF shunt, removal and a complete removal of the complete CSF shunt system without replacement, and this is removal with replacement. So the codes are very specific. Pay attention. What are you doing with that shunt? And these are the code range for the spinal shunt, which are also called as a lumbo-subarachnoid shunt. Now, if you see the code range, there are only very few code. But sometime whenever we are doing the spinal shunting, we have to take out some part of the vertebral column, and in that case, some of them you will see the word no laminectomy which is done, or sometimes you have to do the laminectomy. So without laminectomy, with laminectomy, so the codes are that specific. Again, pay attention to that because that is an important consideration as far as the spinal shunt is concerned. Now the next topic is injection, aspiration and drainage. Now what happens is, in the nervous system chapter there are the topics are haphazardly placed, like for the spinal shunting we went to 64,000, and again for the neurostimulator, some of the neurostimulator, the peripheral one, we went ahead. So either you can do the nervous system wise, that the peripheral or the central, or you can do the topic wise. I have chosen to do the topic wise, that if it is a neurostimulator topic, pick up all the neurostimulator. So whenever you are taking this particular, the YouTube slides, please keep the book in front of you. It will help you. Now, as I said, the injection, aspiration, drainage. The code range is this. Now, this particular encompasses the variety of the injection, drainage, or aspiration procedure on the spine or the spinal cord. This procedure involves introducing substances, removing fluid, accessing the epidural or subarachnoid spaces for the diagnostic and therapeutic purposes. Key point about the codes are accurate code description, and even the region is important consideration, whether you are doing it on the lumbar or cervical or thoracic. Then again, the image guidance is another important thing, whether it is a part of the code or whether you need to code it separately. Parenthetical notes are important point to consider, and that is the important note for all the CPT codes, that you will always read the parenthetical note before you zero down the answer. Now, if you see the code 62263, it is a percutaneous lysis of the epidural adhesion, including multipulsation and radiological localization. These are just an example for you to just know how specific the code is. And this is the code injections. So it includes the multiple injections, diagnostic or therapeutic substances with needle or catheter placement, interlaminar, epidural or subarachnoid, lumbar or sacral with image guidance. So pay attention whether the code includes image guidance or not. That is an important consideration in this code range. So this is the next topic, that is the intrathecal infusion pump, reservoir and catheter. This system delivers the medication directly into the spinal fluid, and it mainly consists of two parts. One is pump and a catheter. The pump, which is also called as the reservoir, it is a chamber within which holds the medication until it delivered through the catheter. While the catheter is a thin flexible tube which connects the pump. So this is the tube which connects the pump to the intrathecal spaces, allowing the medication to be delivered directly into the spinal fluid. So you can see it is connected here, and so it can deliver the medication. This system often used for the chronic pain or the spasticity, which provides the targeted pain relief with a potentially fewer side effects compared to the systemic medication. So this is for that. So these are the code for the system, and you will see that some of the code only for the catheter, some of the code is for the pump. Then pay attention whether you are implanting, whether you are removing. And nowadays most of the pump or the reservoir, they are programmable. But so are you doing the program, are you using the programmable pump, or are you not using the programmable pump, or are you doing the reprogramming of the pump? These are the very important words that will decide your code. So we have finished with lot of theory part, and now we begin with the practice. So the first question is, Todd had a tumor removed from his left temporal bone. How would you report this service? And we have this code. So just go through all the code. So if you see the 61563, it is excision intra and extracranial benign tumor of the cranial bone. And in that example, fibrous dysplasia without optic nerve decompression. Now, our bone is a temporal bone, which is also the kind of a cranial bone. So we have to see all the codes very, very carefully. 61500, it is a craniectomy with excision of the tumor or other bone lesion. And then we have the code 69970, it is a removal of the tumor temporal bone, and 69976 979, it is for the unlisted procedure on the temporal bone. Remember, we use the unlisted procedure code only when we do not have a specific code. Okay, so go through all this code and tell me what is the answer. So yes, D is the answer because it talks about the removal of the tumor temporal bone. Now why the 563 is not the answer? Because it is talking about a benign tumor. In our question, they have just mentioned the tumor, but we do not know the nature of the tumor. So that's why 563 goes away. 500 is a craniectomy. I do not see. Of course, they have removed the temporal bone and excision of the tumor of the or other bone lesion. So this is also one thing which we could have considered, but Whenever I have a very specific code, I will pick up that code. And this is the code, removal of the tumor, temporal bone, and that is why I will pick up the answer D. So let us take the first question. The patient is 64-year-old female who is undergoing a removal of the previously implanted Medtronic pain pump and a catheter due to possible infection. So this is the case where because of the infection, she had to remove her pump and a catheter. So that is a main consideration. And if you see below, what they have given is the complete procedure. And they have told us to do the CPT as well as the ICD coding. So what has happened is the removal of the pump and the reservoir happened. And why? Because she had the infection, and the infection is because of the mechanical device. So these are the three important points. Now, if you see all the codes, we need to check all the codes and we need to pick up the answer. So see, I have given here all the description of the codes. Kindly go through that and tell me the answer. So yes, C is the correct answer because we will require two code. One is for the removal of the pump, one is for the removal of the reservoir. We cannot take the 350 because it is for the implantation and the revision, and this is for the implantation and the revision of the reservoir, but it is without a laminectomy. So these two codes are not at all important code. And then we will require the ICD code, which talks about the infection because of the mechanical device. So that's why we go with the C. So the next question is, the patient is 73-year-old gentleman who was noted to have progressive gait instability over the past several months. MRI imaging demonstrate ventriculomegaly. It was recommended that the patient proceed forward with a right frontal ventricular peritoneal shunt placement with a Codman programmable valve. What is the correct code for this surgery? And we have these options. So what has happened, that is ventricles in the brain have increased in size, and they require to drain that excess of CSF, and what they have put is ventriculoperitoneal shunt placement. And we have all these options, so pay attention and zero down the answer. So yes, B is the correct answer because if you see the A, it is the ventriculoatrial CSF. Then 62223 is ventriculoperitoneal, 62190 is the creation of the shunt, but subarachnoid and subdural atrial jugular. So if we see all the codes, you will see that 62223 is the correct answer. Let us take the next question. It is a patient was taken to the procedure room and placed in the prone position, and L4 L5 interface was identified using the fluoroscopy to determine the injection site. So the patient was supposed to get the injection in L4 L5, and it is done under the imaging guidance. And here all the procedure for the injection is given. Kindly go through the procedure and tell me the answer. Please pay attention. Where the injection is given, it is in L4 L5 interspace. So that is very important, and pay attention to the guidance. So yes, B is the correct answer because we will require the code for the lumbar interspace injection. 62321, it is an indented code and it talks about the cervical and thoracic space, while the 323, it is the code, again indented code. So I'll be reading the above code, and it includes the lumbar and the sacral, and it includes the image guidance. So there is no need to write the 777003 code. And here there is a parenthetical note which also tells you not to use this and this code together. So C and D is wrong option, and we'll go with option B. Now let us take one more question. A 42-year-old patient returns to the hospital neurology clinic for the follow-up. He was checked 3 days prior to this visit, where lumbar puncture was done to find out the etiology of the patient's headache. The headache had increased in intensity over the past 3 days. The neurologist examines the patient and finds the CSF leak from the lumbar puncture. The blood patch by the epidural injection is performed to repair the leak. So Today the patient came for the follow for what, whether the headache has come back or no, and he doesn't have any headache. And 3 days prior to this visit there was a headache, and that headache was fixed by the doctor by giving the patch. And so you go through all these things and tell me, this is the example of the injection. And what injection is of the they have given the injection of the blood or the clot patch. So go through and tell me the answer. So yes, 62273 is the correct answer because it is the injection epidural of the blood or the clot patch. Always check whether it coincides with what is the data is provided into the encounter, and that is what exactly happened. So we will pick up that code. The remaining codes, one is for the diagnostic, that won't go. The 272 is the spinal puncture, that didn't happen here. So what happened is basically proofing that leakage that has happened, and that's why we will go with that code. So what is the full CPT code description of the 61535? So kindly open your book, check that code and tell me the answer. So yes, B is the correct answer because if you see this particular code, the code language says for removal of the epidural or subdural electrode array. And if you see the first word, the first letter is in the small case. And if you remember while teaching you the CPT, I told you that if the first letter is in the small case, that's a clue that it is an indented code. So I'll be reading the above code till the semicolon, and then I will add this, and that's what exactly the language, and that's why B is the correct answer. James returned 2 weeks after the surgery as planned for change in his drug delivery system. Today, Dr. Harvey opened a previously incision site. The previously placed reservoir was removed and a new programmable subcutaneous pump was connected to the catheter and secured with suture, tested and programmed. The subcutaneous incision was closed in layer with sterile dressing. Place. The patient tolerated the procedure. Now what has happened is the doctor done the surgery and he called a patient after 2 weeks, and it was planned. That is a very important because you see a lot of modifiers here. So it will help us to zero down the answer. So tell me what is the answer. Go through all these codes and the data that you have collected. So, the previously reservoir is removed and new programmable subcutaneous pump was connected to the catheter. So tell me the answer. So yes, A is the correct answer because if you see the D, it talks about implantation of the external pump and the removal of the previously implanted catheter. That didn't happen. 62350, it talks about the implantation and revision repositioning of the tunnel catheter as well as, but it is a pump what they have used in our case they haven't talked about the external pump. And if you see the 62362, it talks about the replacement of the device. That happened because they took out the old one, previously placed reservoir was removed and a new was given. So it is a replacement that has happened and the replacement of the programmable pump that has happened. So we will go with 62362 and 58 modifier. Carl, 28-year-old patient, has a history of epilepsy with recurrent seizures. His seizures are intolerable even with a medication management. He does not experience non-epileptic seizures, which was confirmed by EEG recording. Today he underwent an open procedure for implantation of the cranial nerve stimulator, neurostimulator electrode array, which was coiled around the vagus nerve. The pulse generator was connected to the neurostimulator array, tested and repositioned to ensure maximum effectiveness. The pulse generator was placed and sutured into created subcutaneous packet. So this is a question of neurostimulator, and I told you that we have a various kind, the cranial, the spinal and then the peripheral. Ours is the vagus nerve. So that is also an important consideration. So just go through all the codes and tell me the answer. So if you see the option B is the correct answer. Now let's decipher the answer. That, see, if you see the code 64568, it talks about the implantation of the cranial nerve, in bracket vagus nerve, neurostimulator, electrode array, and a pulse generator. That's what happened in our patient's case. So we will require a code 64568. But below that, in the bracket, they have written do not report 64568 along with the code 61885, 886 and 64570. So that automatically helps us to eliminate the option A and option D. And if you see the option C, that is 531, you will see that it is a subdural implantation of the strip electrode through one or more burr or trephine hole for long-term seizure monitoring. So that didn't happen. Whenever we are putting this neurostimulator in the cranial area, we do the burr hole or the trephine surgery. That did not happen. So B is the correct answer. So this is my last slide of this presentation, and we'll go with the part 3 and part 4. So remember always, whenever you are preparing for the CPC exam of any section, focus on understanding the anatomy, focus on understanding the terminologies, familiarize yourself with the CPT code, particularly those related to the nervous system, then understanding the surgical prefixes, suffixes, and a little bit of understanding of that procedure is crucial for you to code it rightly. So we'll begin with the nervous system part 3 later.